This video is about Prom and Pprom. We'll talk about the etiology, the diagnosis, investigations, and management of Prom and Pprom patients. Prom is the rupture of membranes at 10. Okay, so what does that mean? It means that the membranes have ruptured at 10, which is 37 weeks, but the onset of labor hasn't occurred yet. There are no uterine contractions and there are no labor pains, but the membranes have ruptured. The letters Prom stand for premature or pre-labor rupture of membranes. Pprom, on the other hand, is the preterm, pre-labor or premature rupture of membranes. So the membranes rupture before the onset of uterine contractions and before any labor pains, and it occurs before 37 gestational weeks. The risk factors of Prom and Pprom can be categorized into membranes, pregnancy, cervix, modifiable, history, and infection risk factors. Under membranes, we have lack of resistance of membranes, such as in vitamin C deficiency, as well as in collagen disorders that cause lack of tensile strength in the membranes so that they easily break. Then there's aggressive external factors such as amniocentesis. Pregnancy, we have multiple pregnancy, polyhydramnios, macrosomia, or a big baby such as occurs in diabetes mellitus. Under cervix, we have short cervical length, cord biopsy, cervical incompetence, surgery on the cervix. Modifiable risk factors means that you can change your lifestyle, and then these things can actually not contribute to Prom. So under modifiable risk factors, we have smoking, alcohol, low BMI index, low social and economic status. Then under history, we have history of prior preterm labor before or history of Prom before. Okay, and infections such as bacterial vaginosis and other touch infections can cause Prom through their modes of infection, such as by the release of enzymes such as proteases and phospholipases. All these can reduce tensile strength in the connective tissue. The diagnosis of Prom or Pprom is based on history and examination. So from your history, you want to find out draining of amniotic fluid. You want to find out how many pads the lady has used from the onset of draining, and then you want to find out how the draining started. The patient will usually describe a gash, okay, just a gash, and then draining onset. From your examination, you want to perform a sterile speculum exam using acoustic speculum. You are going to see the pulling or draining of lichor in the posterior fornix or the part of Douglas. You may see hyperelic cervix, which means that there's possible infection, and you will also find dilatation of the cervix. The complications of Pprom or Pprom can either be maternal or fetal. On the maternal side, we have infections such as chorioamnionitis, abruptio placenta, preterm labor, prolonged labor, increased risk of C-section delivery, as well as amniotic fluid embolism and increased or painful labor, because what your amniotic fluid actually does is it's a lubricant so that it reduces the friction during birth. Your fetal complications include infections such as bronchopneumonia. We have prematurity as a result of preterm delivery, IUFD or intrauterine fetal death, malpresentation, pulmonary hyperplasia of the fetus, amniotic fluid burns, cord compression, cord prolapse, risk of mechanical shock, contractures, and fetal distress. So after your sterile speculum exam, you can do a number of tests under investigations. You can do the nitrogen test, which involves you getting the fluid from the vaginal examination and you place in a litmus paper or a nitrogen paper. It will turn blue because amniotic fluid is alkaline. However, there may be false positives, other things that can cause the litmus paper to turn blue, such as urine, semen, blood, in bacterial vaginosis, as well as in trichomoniasis. You can also perform the Fen test, which involves you getting the fluid from the vaginal examination, you place it on a slide and you let it dry. Then when you view under the microscope, you're going to see narrow fins if it is amniotic fluid, or broad fins if it is cervical mucus. The fins are crystals of sodium chloride. Other investigations include a high endocervical swab for microscopic culture and sensitivity, a white cell count, total and differential, as well as biophysical profile for fetal well-being. Under management, we have active management to expectant management, which would include bed rest and pelvic rest. Also give an antibiotic cover using erythromycin. Erythromycin is important because it increases the latency period. The latency period is the interval between the rupture of membranes and the onset of labor. Then we can also give corticosteroids, especially dexamethasone. Now, dexamethasone has important functions, 4 important functions. It is important for fetal lung maturation. It also reduces the risk of necrotizing enterocolitis. It also prevents intracranial hemorrhage, and it also reduces thrombocytopenia of the newborn. Then we can also give tocolytics, which are beta-2 agonists such as salbutamol or ritodrine. Then Prom at term or near term is best delivered. Between 32 and 36 weeks, give steroids for lung maturation. Under 32 weeks, aim to prolong gestation if there is no sign of fetal distress or infection.